This is an ABC podcast.
Hello and welcome to this week's Health Report with me, Norman Swan. Today we'll have dentists and orthopaedic surgeons at my throat, but hey, what's new? We'll have a story on fresh guidelines on the treatment of one of the commonest causes of shoulder pain. Little or no role for surgery, they say. What benefit one of the commonest procedures done by your dentist at your 6-monthly visit? Which exercises are best to prevent falls, a common reason for older people to end up in residential care? And should scientific journals publish papers on transplantation from China when the organ donors have been executed prisoners of conscience? But let's get back to your oral health. We're told by dentists to come and see them every 6 months, and inevitably you end up having a polish and scaling, which means the removal of stains, plaque and calculus, or tartar. That's the hard stuff the dentist has to howk out with one of their curved probes. One reason for polish and scaling is cosmetic, given our coffee addiction and the consequent staining. The other is to prevent gingivitis or gum disease. But does scaling and polishing do this? That's what a group of dental researchers wanted to find out. The lead author was Thomas Lamont of the University of Dundee, who's on the line from Scotland. Welcome to the Health Report, Thomas.
Thanks, Norman. It's a real pleasure to be with you on the show.
You're a practicing dentist, and just very quickly, I believe, just to be folksy, your brother's a dentist in Sydney.
Yeah, that's right. He's just moved down. He's just moved down to Australia now, so he'll be listening from his surgery just now.
Great
so,
stuff.
Hi, Dominic.
Okay. Nothing like a cheerio from the programme. So just tell me, there's not that much research done into polishing and scaling, is there? You only find two studies.
Norman, it's, as you've already said, it's one of the most commonly delivered dental interventions or dental treatments, and many adults around the world will be used to going to their dentist on that 6-monthly basis, and they'll normally receive a scale and polish, which is really meant as a supplementary form of plaque removal. So it's an additional way of removing the plaque, and it's supposed to help the patient's own home care. But traditionally that has involved a scheduled 6-monthly scale and polish, irrespective of an individual's risk of disease.
So these two trials did what? They randomised people to scaling or not?
Yes. So the research that we've conducted is a Cochrane review, which pulls together the best available evidence. So the two studies that we have included in the review have both been randomised trials based in the UK general dental practice setting, and they both included regularly attending adults without severe periodontal disease or severe gum disease. So both of the studies were actually conducted in the settings and on the populations that are of direct relevance to us.
And you followed them for
common.
So you followed them for 3 years, and what did you find?
What we've found is that the results really question whether the scale and polish should be delivered on a Schedule 6 or 12-monthly interval basis, because the updated review shows that providing that treatment doesn't really make much of a difference compared to when the dentist thinks it's indicated or when the patient actually asks for the treatment. So far as health outcomes are concerned, there's no difference between any of the groups. And
did it successfully reduce plaque and tartar?
So what we found is that there's no difference in those in the gingivitis score. So gingivitis is an early measure of gum disease, and over the 2 and 3 years there was no difference between either of the groups. But what we did find was that patients do like that clean feeling that they get when they've had that scale and polish treatment done. But it doesn't we don't know that there's any real clinical benefit in terms of reducing gum disease.
Now, the Health Report is known for having a go at doctors for their lack of evidence-based practice, but dentistry's got even less research. So does this mean, the dentists say come back every 6 months. Is there a shred of evidence that coming back every 6 months makes a difference? So scaling and polishing is not going to prevent gum disease. That's the first thing you found. Second thing, why would you bother coming every 6 months to see your dentist? What evidence is there for that?
So you are right, we are looking to improve the evidence base in dentistry. This review, it's good to be clear at what this review is looking at and what it's not looking at. This review is purely looking at scale and polish intervals. Your question of how often you should come back to see the dentist is actually extremely timely, because there's a large randomised trial being conducted in the UK that's soon to be published on that very area. and it's looking at scheduled or risk-based intervals to come back to your dentist. So those results will be out very shortly.
All right, so don't sell your Mercedes just yet. We'll wait until that happens. So basically, if you feel that you need it, and we only have a few seconds left, what are the risk factors for gum disease then, and how do you prevent gum disease?
So really the most important factor is how well you're cleaning your teeth. So that if you go to your dentist and your dental hygienist, they'll show you how to best clean your teeth to reduce your risk of developing gum disease, as well as smoking and diabetes. So if you can cut out smoking as well. So visit your doctor to get smoking cessation advice.
Good. Look, thank you very much for joining us, and I hope your brother was listening.
Thank you so much. Have a good day.
Thomas Lamont is a clinical research fellow and practicing dentist based at the University of Dundee. And you're based at Radio National, ABC News or CBC Radio, and are listening to The Health Report with me, Norman Swan. One of the commonest causes of a sore shoulder, limiting movement, is called subacromial pain syndrome, although it's often called a rotator cuff disorder. A frequently used treatment is surgery to decompress the tendon as it runs under the bone at the top of the shoulder. That's the acromion. A new clinical guideline for doctors suggests that surgery doesn't help and could cause a frozen shoulder. Rochelle Buchbinder was one of the authors of the guideline. Professor Buchbinder is a rheumatologist and clinical epidemiologist at Cabrini Hospital and Monash University in Melbourne. Welcome back to the Health Report, Rochelle.
Thanks, Norman. Pleasure to be here.
So what are the signs and symptoms of subacromial pain syndrome?
So it's usually pain that's felt in the upper outer part of the arm, so not on the top of the shoulder but in the upper arm. Often it's very painful to lie on the affected side and people wake up at night with pain. And then movements particularly up in the air from the side or the front, and also moving the arm behind your back will cause significant pain.
So moving your arms to the side, moving your arms to the front or to the back, that
yes.
Induces pain and is limited.
Yes. The movement is normal, but it's limited because of the pain.
And is that the diagnosis, or do you do any special tests on it?
No, it's a clinical diagnosis. It's really the most common cause of shoulder pain in middle-aged and older people. And really the only differential is a frozen shoulder where you also have pain, but the movements are very restricted. And in older people, the differential diagnosis is osteoarthritis of the shoulder joint itself. But often it's quite easy to tell clinically.
So what causes subacromial pain syndrome? Do we know?
Well, we don't know really, but we know that there's wear and tear in the rotator cuff tendon. So if you do imaging in middle-aged people, about at least 1 in 10 people will have little tears in their rotator cuff. So it's a part of the ageing process. So
this is like a conversation you and I have had before, which is if you do an MRI on people aged 50 and their knees, it'll show wear and tear and even a torn cartilage, but it doesn't necessarily have anything to do with whether or not you've got knee pain or how much knee pain you've got.
Sure, that's exactly right. And so the theory for many years has been that the tendon gets squashed between the bones, as you were saying in the introduction. And so for people that have ongoing pain, then the treatment has been to try and make that space bigger so that the tendon isn't squashed.
And so where does the criticism of surgery come in and the evidence base for that? Because this is the core of the new guideline, which is quite anti-surgery.
So last year in 2018 there were 2 trials published, one from the UK and one from Finland. Both of the trials compared surgery to a placebo group. So the placebo group just had an arthroscopy, so they just looked into the shoulder joint, but they didn't have the decompression. And the decompression consists of making the space bigger, often taking the end of the acromion, the bone, away and removing the bursa. And both trials were actually very similar in outcome, and they found that doing that compared to having an arthroscope resulted in almost no difference in outcome in terms of pain or function or quality of life or how successful the patient thought the procedure was. And those results were the same out to 1 and 2 years.
And so that's what's led to this guideline, which suggests there's almost no role for surgery in subacromial pain syndrome.
That's right. So these are people who don't have a full thickness tear of the rotator cuff. These are people that just have that impingement. And so there are 2 trials, as I said, compared to placebo. Even before those trials were published, there were about 6 trials that compared surgery with exercises or rehabilitation, and even those studies didn't suggest that surgery had a role, actually.
And what gives you a complete tear of the rotator cuff? Is that a physical injury?
In young people and acute trauma, that could be an acute injury. But again, it's an ageing process, and as you get older, there are tears in the tendons, and sometimes, particularly because we're living longer, that can result in tears of one or more tendons in the shoulder, and partial tears and then complete tears.
So I assume that the practice is continuing, that surgeons are continuing to do this operation?
Yes, so they are continuing. There's been a big increase in places like the UK. I've had a look at our Australian data, and there's a 3- to 4-fold variation between states in the numbers of these procedures, and there's about 900 to 1,000 a year, although the numbers, it's a bit hard to tell as there are more than one item number that you can use for this procedure.
So what's a person to do if surgery is not going to help? Do we know? I mean, I remember doing an interview with somebody at the University of Glasgow where they talk about eccentric physio, which stretches the tendon, having some benefit when you do randomised trials.
Well, we've actually done a Cochrane review that was published a year or 2 ago that included 61 trials of physiotherapy and exercise and also manual therapy for this condition. Among those 61 trials, there was only one placebo-controlled trial, which was performed in Melbourne, led by Kim Burnell, and that one didn't show any benefit over placebo either. And when you look at the whole evidence across those 61 trials, there's not strong evidence that even exercise makes a difference, and we know that often this condition just can get better over time. So we really don't know how to treat it if people have persistent symptoms, but often the pain, like many of the other conditions that I've spoken to you about, gets better over time, and you just have to wait. It can be up to a year or so. And
very briefly, steroid injections, do they make a difference?
Steroid injections have been proven to have short-term benefits, so they're really useful when you're in a lot of pain, particularly the night pain, but they wear off, and so hopefully by the time they've worn off, the natural history for improvement occurs, but you can also repeat the injection.
Rochelle, thanks for coming back on.
Pleasure, Norman.
Professor Rochelle Buchbinder is Head of Clinical Epidemiology at Monash University and is a rheumatologist at Cabrini Hospital. This week is the start of hearings at the Aged Care Royal Commission, and one of the most frequent precipitating events leading to an older person needing residential care is a fall. And that's not to mention the human and financial costs of injuries such as fractured hips. There's been a huge number of studies into falls prevention. These include practical things in the home, such as handrails in the shower and looking for places where a person could trip or slip. But another intervention is exercise, and a review of the evidence has confirmed its importance and indicated which forms of exercise are best at preventing falls. The lead author of this Cochrane review was Kathy Sherrington, who's Professor in the School of Public Health and the Institute for Musculoskeletal Health at the University of Sydney. Welcome to the Health Report,
Thank you.
Kathy. So what did we know before this review?
Well, we did have a fair idea that exercise could prevent falls. We'd done previous reviews, but really the amount of evidence has been gradually mounting, and really the strength of the evidence has been mounting.
And this is before you end up in residential care, or while you're in residential care, or both?
Correct. Our review is just looking at community dwelling older people.
And so what did you find when you did your review?
So
this is a review of there's now a large number of trials.
Yes.
Unlike our first study into scaling, which was 2 trials. There's now hundreds.
Indeed, and it seems to work as well. There's 108 trials altogether, and so that's any type of exercise. And overall, there was around a 23% reduction in the number of falls in people who'd undergone exercise programs.
So now that you've got that number of trials, does it tell you what kind of exercise? Could you be doing aerobics? You could be doing strength-based exercises. Yep. What works?
Well, that's exactly right. Now that there's more evidence, we were able to tease out and look separately at different types of exercise intervention. And so we found that exercises that targeted balance and functional performance had the biggest effect, or had the strongest evidence of effect. We were able to say a high certainty evidence that falls were prevented by this type of exercise. So often we hear about aerobic training, we hear about resistance training, but we don't always hear about coordination training. But really, balance is the ability to coordinate different muscles and, really move within the environment safely and respond to challenges. And so it was interventions that targeted that ability. So the
analogy here is if you're playing rugby, rather than sitting in the gym strengthening your biceps and your thighs, you do match-based training, which actually teaches your body how to play rugby safely.
Yep, that's exactly right.
So this is about how to walk and how to get up and that sort of thing.
Yep, that's exactly right. And that principle of specificity of training, hasn't always been talked about with older people. And so we do see sort of seated programs and things, but really
seated programs?
Seated exercise, so exercise sitting down. But really, the trials in this study that targeted balance and functional abilities all involved programs that were standing up. And so
going for a swim in the hydro pool is not going to cut it?
No.
So just give me an example of some of the exercises that work.
Yep. So really controlling where the body is in space, so reaching, stepping, we need functional leg strength, so really practicing getting out of a chair or doing squats and stepping up onto steps, things like that. But often in these programs, they're included in a fun way, so they might be incorporated into games and things like that. Some of the programs were in a group setting, but others were at home. So we do also know that people can be taught to do these exercises at home.
And are they safe, given that you might be a bit unsteady on your feet and you suddenly decide to do a wobble board at home?
Well, that's a key point for practice, is that it is really good to seek some professional instruction from a health professional or an experienced exercise leader, and all the trials in the studies involved that.
We'll come back to that in a second. So effectively here what you're saying is that you're not just strengthening muscles, it's called neuromuscular training. So it's the brain and the muscles working together.
Exactly. Yep.
There's a little bit of evidence that this improves your thinking ability too, isn't there?
Yeah, I think the jury's still out on that one. Yeah, but there is some.
So it's fine us talking about it. A lot of elderly people live by themselves. Gyms are expensive. What's the extent, and presumably, I'll ask you the question, have there been health economics studies showing that actually this is, if you invest in this, it's worth it, you get a return on investment?
Well, yes, with our colleague Kirsten Howard at the University of Sydney, we did do some cost effectiveness modelling, and we did actually find that if we were to better invest in these type of programs, it would be cost effective at a population level. Because you're right, many people don't have access to these type of programs.
What about Tai Chi?
Mm-hmm. So Tai Chi also was effective. There's a little bit less certainty there. We were only able to say low certainty evidence in the Cochrane parlance, basically because there's fewer trials and a bit more variability between the different trials.
Coming back to a question I was going to ask earlier, but now's the time to ask it. So it's fine talking about all this stuff. How do you implement it? Where do you go? Are there community programs? This could save people years at home. And not require residential care.
No, that's exactly right. And really there's not enough awareness amongst the community or amongst health professionals about the strength of this evidence.
But if you're a GP sitting in a surgery, where do you send a patient?
Yeah. So some states have sort of searchable databases. The New South Wales Health Department has the Active and Healthy database where health professionals and also members of the community can search for suitable exercise programs. The other thing would be to speak to a physiotherapist or an exercise physiologist to have a home program prescribed. Because as you mentioned before, doing exercises that are too challenging might actually increase the risk of falls, and exercises that are too easy won't do anything. So it is a matter of really targeting exactly, just like with athletes.
Kathy, thanks for joining us.
Pleasure.
Kathy Sherrington is Professor in the School of Public Health and the Institute of Musculoskeletal Health at the University of Sydney. Organ transplantation is life-saving, whether it be a heart, liver, lungs or kidneys. And given there's still a lot to learn about controlling rejection and the best way of doing transplants, research is still incredibly important. China carries out many thousands of transplants and has a sophisticated scientific community, so potentially there's useful Chinese data to learn from. Except that the evidence points to a huge human rights concern, namely the use of organs of executed prisoners for organ transplantation. Now, a review says hundreds of scientific papers are most likely using data which comes from executed prisoners, despite international journals agreeing not to publish papers containing such data. Professor Wendy Rogers is Deputy Director of the Research Centre for Agency, Values and Ethics at Macquarie University and lead author of this review. Welcome to the Health Report, Wendy.
Thank you, Norman.
Tell me about this 2016 paper that raised your hackles.
Well, in 2016, there's a paper published in Liver International that showed, that reported on some 500-odd research subjects who'd received liver transplants. And the authors specifically stated that no organs from executed prisoners were used. Yet the transplants took place from 2010 to 2014. And during that time, there was only a very small volunteer donation program. So it seemed unlikely that they could have done all the transplants on volunteers. They would have needed just about 50% of all the volunteer transplants in China. So we thought...
So just explain those data, because there is a ratio. This is like us registering with our driver's licence, and there's a ratio of we don't all die every year, therefore there's a trickle of transplants that come from people who've registered as a voluntary donor.
That's right, but in China they claimed that they had so many volunteer donors per year who'd actually made the donation, who'd actually died. So in 2010 there were 30-something or other, 100 and something the next year and so on. So during the period of the research, the researchers would have needed to have had 50% of all the volunteer donated livers in the whole of China. And that just seemed implausible. So with the help of a Chinese-speaking researcher, he looked into the hospital where the transplants had taken place and found out that that hospital hadn't joined the pilot until after 2010, when the first transplants in the research were reported, and it was only approved to take hearts from donors, not livers. So we felt that the authors were not telling the truth.
So this led you to look at this more deeply?
It did. We thought, well, if one author or one group of authors is lying to the journal and claiming that the organs are from volunteers, maybe it's widespread. So we decided to do a scoping review, which is like a systematic review but slightly less rigorous methodology.
But how do you do something like that? Looking at the same data, is it possible to have got these organs from a voluntary register?
Well, basically we looked at when the transplants took place. So we looked at how many transplants, which organs, when they took place. Prior to 2010, there was only about 100 volunteer donations in the whole of China. In the whole of China? From 2000 to 2010. And that was out of the mouths of the Chinese experts themselves. And they freely admitted...
So even fewer than Australia?
Yeah, so they freely admitted that prior to 2010, all organs for transplantation came from executed prisoners. Between 2010 and the end of 2014, they implemented a volunteer donation scheme which permitted prisoners to volunteer, with no distinction made between prisoner volunteers and citizen volunteers. Right. And the claim is now that it's all volunteers.
Okay, and the conclusion you came to was what?
The conclusion was that all of the papers, all 445 papers, included organs from prior to the 1st of January 2015, when the claim was that all organs are voluntary. So it's possible that all of the papers involve organs from executed prisoners, but all of the papers reporting on transplants prior to 2010 must involve organs from executed prisoners because there was no other source.
And you don't believe, not that there's morally or ethically any difference here, that they're all from criminal prosecutions, people who've murdered somebody else, for example, and you're being executed for murder. You think the prisoners of conscience are being involved here? I do. What's the evidence for that?
The evidence for that is looking at numbers of transplants in hospitals, numbers of transplants done by doctors, the availability of organs on demand for tourists who can book a heart transplant 2 weeks in advance, the scale of transplants that are taking place. And recently the China Tribunal in London, chaired by Sir Geoffrey Nice, looked at evidence of 30 people over 3 days. And the tribunal, which is 7 independent human rights lawyers and others, concluded unanimously and beyond all reasonable doubt that harvesting of organs from prisoners of conscience was taking place on a large scale in China.
Who are these prisoners of conscience?
They have been primarily practitioners of the Buddhist school Tai Chi type practice of Falun Gong. More recently, we've also heard of Tibetans being incarcerated and disappearing. Some small groups of Christians who are not practicing according to the approved Christian sects in China. And most recently, the Uyghurs. You'll be aware that there are over 1 million Uyghurs detained in the northwest province of Jiangxing in China. Nobody's coming out of those camps.
Now, there are ethical guidelines that have been agreed, and have been agreed for, 12 years? I mean, it's quite some time. Just tell us about the ethical guidelines that govern the transplantation literature, or supposed to. Yeah.
Well, it's been universally agreed by the Transplant Society, by the World Medical Association, by the WHO, by the Declarations of Istanbul Custodian Group, that it's unethical to procure organs from prisoners who have been sentenced to death because they're already in a completely coercive situation with complete loss of all their freedoms. It's not considered that they can voluntarily donate, and it's not considered ethically appropriate to pillage their bodies once they've been executed. And on the back of that, it's widely accepted that if you shouldn't use the organs for transplantation, then you shouldn't use the organs in research either. And the Transplant Society came out with policy on that in 2006 and stated explicitly that they wouldn't accept research.
And you've looked at the compliance of scientific journals with that guidance.
That's right.
And to what extent has it been complied with?
Less than 10%.
So fewer than 10% of international journals are complying with this guidance. So they're
of the papers we looked at.
So they're publishing data on executed prisoners. Why are they doing that?
It's unclear how and why it's happening. So first of all, the papers, these were all peer-reviewed journals, so the papers have been through peer review. So either the reviewers weren't aware where organs come from in China, or recommended against publication. Then goes to the editor. Same for the editors. Either they were unaware where organs come from, or they knew but decided to publish anyway. And then you've got the journals and the publishers who have a lot of interests in China.
We're running out of time, but very quickly, this is a debate that came up with the Japanese war experiments in Harbin and also Holocaust experiments in concentration camps. And people said, well, if you throw away this data, you're throwing away valuable data about hypothermia or shotgun wounds or that sort of thing. Is there any evidence that by not publishing this, we're throwing away good information?
Not yet. We haven't studied the quality of the papers, but generally, no, not generally, quite often research validity and quality tracks with ethics.
And in fact, the Holocaust research and the Harbin research was not of good quality, and people don't think that. So what's to happen now?
Well, we've called for a retraction of these papers pending investigation. It's possible that a small number of them did use ethically sourced organs, but I think the onus at this stage is on the researchers to prove it. We believe there should be a summit with all the key stakeholders to try and work out what are the key outcomes and data points that should be included, so that you can't shoot someone and say, oh, it's a DCD, donation after circulatory death, but there's no warm ischemic time. Those are sort of technical points, but they'll help to disclose how the organs are procured.
And hopefully make it shrink on the vine. Thank you very much indeed for joining us.
Thank you.
Professor Wendy Rogers is Deputy Director of the Research Centre for Agency Values and Ethics at Macquarie University in Sydney. I'm Norman Swan. This has been The Health Report. See you next week.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio and exclusives on the ABC Listen app.